Hi, everybody. It's Karen Anderson here with Aortic Hope for our week in review. And before we get started, because what a week it's going to be, I need you guys to click the link below that says like. Click that little thumbs up. Click share when we're done. Click the bell. Click subscribe. Click all these things. The main reason for the bell is because you want to know every time we go live, because we go live for this every Monday, which gives you an opportunity to interact with me or us, depending on who I have joining me for the day, and talking about our posts from the prior week. We also go live when we have a lot of brave souls talking about their survivor story, and we go live with a variety of Q&A events with all kinds of people, doctors, surgeons, cardiologists, attorneys to talk about the disability process, therapists, like all kinds of things. People from Lawrence Hope, we've had them all. And you want to be part of that because sometimes we do giveaways, and that's awfully a lot of fun. So click all of that. And then when we're done, click share and leave a comment. I've covered it. I covered every single week. But right now, we're going to get started on this weekend review. We may have a surprise guest jump in to join us. Otherwise, it's you and Invisible Joshua. You there? You're there. You're always there. Kind of like the wind, right, Josh?
Bo is here.
Bo is here.
He says he
Bo's great.
doesn't know anything about sending us pictures for tomorrow's video. I'm going to rectify that right now.
Yep, fix that because tomorrow's going to be a great day when we get to show our fifth annual Hope campaign. And we're going to talk about that in a few minutes. We're going to get to that. That's always some fun and exciting. But it is officially today. Well, actually started yesterday. If you think of your week starting on a Sunday, it is the week of Aortic Disease Awareness Month. Although here at Aortic Hope and many other places, we tend to look at aortic disease awareness in terms of an entire month because there's just way too much for us to talk about in 1 week. And yes, a aortic disease awareness day is on September 19th, and we have a lot of exciting things to share with you officially tomorrow. But this is part of our month, and we have been presenting a lot of information to you. Everything from Aortic 101, what's the aorta, thoracic aortic aneurysms. We've talked about abdominal aortic aneurysms, aortic dissections, aortic valves, genetic screening. We've talked about so many medical things, dissections. All of the great medical stuff is primarily out of the way. We're going to move more into the support and resources section, that all of this stuff you can find in Aortic Dissection, the patient guide. We're kind of following along uh, the way that those chapters are broken out, even though we cover everything. Because dissections are so rare, we like to cover all the other elements that tend to be much more common than anyone realizes. So without further ado, let's get into aortic valve 101. That's what last week's Monday was all about. And again, for these medical posts, we have our third year medical student, Adam, and our fourth year Duke providing us with all of this information that they're able to source out there in the medical internet. And let's get into it. Okay. So, uh, this one is from Adam. We actually got a chance to meet him when we went to the Aortic Disease Awareness Walk hosted by Aortic Bridge, although there was no walk because it was like tropical storm rains that day, which is totally fine. We made it through. We ate a lot, and yeah, and it was great. But we're gonna talk about aortic valves, okay? So as he says, picture this: the right side of your heart just got all of the venous non-oxygenated blood from the body. It effortlessly, I love the way he describes things, it effortlessly carries it to the lungs, which give it a beautiful supply of oxygen and feeds it to the left side of the heart. Your left ventricle is now full of oxygen rich blood. And now it's time to pump all of this blood out of the heart into the rest of the body. And what do you think that goes through? That's going to go through the valve and the aorta. Here's a great picture of our hearts. Okay, there we go. And this is again where the aortic valve plays in. See, there's your aortic valve, and all that oxygenated blood came over to here and is now going to go up here and go everywhere down below, behind the heart, and to the entire body. All right. Think of it as a gateway between your heart's left ventricle and your body's aorta. So the door from the heart to the rest of the body That would be your aortic valve. And most aortic valves are made up of 3 thin leaflets, which we did talk about in prior posts. And these leaflets are called cusps. These cusps, they open and close to allow the blood to flow in one direction. Okay, here we are. There's your normal aortic valve and your 3 leaflets. And this is what it looks like when it's closed. It goes right here. This is what it looks like open and closed. Okay, blood comes from here, goes through the aortic valve and into the aorta. When your heart pumps, the aortic valve leaflets, they open, allowing the oxygenated blood to flow from the left ventricle into the aorta and throughout your entire body, providing energy and oxygen to your muscles and your organs. And after the heartbeat, the cusps close tightly, preventing blood from returning to the heart. Let's talk about some of the diseases that can happen to the aortic valve. Now, there are a few things that can happen from the day you're born, which would be a bicuspid, a unicuspid, quadcuspid, I suppose, when you have more than 3 leaflets or less than 3 leaflets. That would be considered a congenital heart defect because this is something you're born with. It's not something you can catch, although they're realizing that they believe that bicuspid would be potentially hereditary. So that's something to think about too. But these would all be diseases that can affect your heart and your valve. Okay, so aortic stenosis. We hear this a lot. What is aortic stenosis? As we get older, calcium and fat deposits along our blood vessels and our organs. It's just what happens. Just what happens. Probably from all the different things we eat, pick up in our life, lack of activity, what have you. But in aortic valves, the calcification causes it to narrow and causes it to harden, making blood flow more restricted between the heart and the aorta. The heart now has to pump harder and could cause symptoms such as chest pain, dizziness, like if your brain doesn't get enough blood. And in some severe cases, it can cause heart failure. So that would be aortic stenosis. Here's a picture of it. You have a healthy heart beating, valves opening. Okay. Now, when you have stenosis, the valve can't actually open fully. That aortic valve is right here, right here. Here it is open, nice and full. When you have stenosis or hardening and narrowing of that valve, it makes it difficult because it won't open up all the way. It makes it difficult for the blood to flow. Now, aortic regurgitation, which is sometimes called aortic insufficiency, and this can be graded anywhere from trace amount of regurgitation to severe amount of regurgitation. And it can change. That was a new one for me. Unlike aneurysms that tend to grow, they do not get smaller, they don't shrink. An insufficiency can actually go from trace to moderate back to trace. If you have high blood pressure, it could go up to, it can go from mild to moderate, it can go back down. A lot of different variables that can happen with your aortic valve. I am not a medical professional. I'm simply repeating the things that we have on all of our videos when we've interviewed cardiologists and surgeons. Again, so aortic regurgitation, sometimes called its insufficiency. This is when the aortic valve doesn't close tightly, which causes some of the blood to leak backwards instead of going forward. That's regurgitating. If you think about GERD, gastric regurgitation, you have acids, or sometimes you ate a really big meal, and instead of it working its way through the intestine, it comes back up your throat. It's like basically the same concept. You're just going to have some blood flow going back into the heart instead of being able to go forward through the body. Symptoms can be similar to that of stenosis, including chest pain and difficulty exercising. So let's see if we can get a good picture here. Normal valve operation. Everything's moving through the valve from the left chamber of the heart. This is what leakage looks like. You have some backflow, goes back into the heart. Okay. By a certain age, I think most people tend to have trace amounts of regurgitation, probably in your mitral valve, your pulmonary, this would be normal, not anything to be concerned about, depending upon any symptoms. And it's a good time to have a conversation with your physician if these types of results come back from, let's say, an echo or a CT scan. All right, bicuspid aortic valve. This would not be a disease necessarily. It's not something you just obtain. This is going to be with you from birth. You're probably not going to know about it until you have an echo because you're having a test done in preparation of a surgery. Maybe you find out about it because someone in your family had an aortic aneurysm or dissection, and you went for your echo just to be checked out, and you found out, oh, look, I have a bicuspid valve. There are some issues that can potentially happen when you have a bicuspid valve. Again, that is with you since birth. That's congenital, and that would be considered a heart defect. So again, bicuspid means 2 leaflets instead of 3. The body is an amazing thing. And in order for your valves to work effectively from the start, you need to have 3 leaflets. It's just the way we were built. I don't understand why. I don't know why 2 doesn't work as good as 3, but it doesn't. So 2 leaflets now have to try to do the job that 3 do in keeping something closed. And when you only have 2, or you have 1, or even if you have 4, it makes the valves more susceptible to wear and tear. And individuals with a bicuspid aortic valve are more likely to develop stenosis or hardening or regurgitation earlier in life than somebody else. And again, when you have those problems, you're more at risk for developing an aortic aneurysm, therefore, more at risk for developing or enduring an aortic dissection. See how all this goes? It's all connected. It's all connected. Again, normal valve, 3 cusps, 3 leaflets. There we go. Bicuspid has 2. To me, I don't understand why it doesn't work as well. But again, they're saying it makes the valve have to work a little bit harder than having 3. This is just the way it is. And this is the area, again, where these mechanics happen. Diagnosis and management. So your doctor can actually order a variety of tests to review and look at the aortic valve, measure its size and its function, and identify if there are problems of tightness, which would be stenosis, or leakiness, which is regurgitation, or leaflet abnormalities, which would be bicuspid or a different type of cusp situation. And some of the common tests that are actually ordered would be an echocardiogram, could be a CT scan, could also be an EKG. And we're actually going to talk about this because this was in another post during this week, last week. Okay, the management of aortic valve disease actually depends upon so many different factors. This would include your age, the severity of stenosis or regurgitation, and any vascular anomalies or any issues in the anatomy. Your doctor is actually going to take an in-depth look at your history and recommend either conservative, which would just be medical treatment, medication, stuff like that, which might help optimize your valve function. And that would be, an appropriate type of treatment. Again, if you're having blood pressure issues, they obviously are going to want to bring down that blood pressure and your heart rate to help delay any significant treatment plans with that valve. But if severe stenosis or regurgitation develops, the treatment is usually aortic valve replacement. Okay, and that could either be through open heart surgery or newer technologies such as a transcatheter aortic valve replacement, or TAVR, transcatheter aortic valve replacement. In these kinds of surgeries, a really small cut is made in your groin, your shoulder, or it can be in your neck, and a small tube-like catheter is used to deliver and deploy this aortic valve. It's crazy to me that somebody can do that. Go right up into your groin, let's say, and poof, let out this brand new valve that just kind of goes right into your own valve. It doesn't replace it. Just boop, there it is, and it just starts functioning and keeps everything held together. Well, it actually could replace your valve, but it still goes in without the need of it being open heart. Like, this is all scientific stuff to me, like really like stuff you watched back in the 50s kind of things are coming to life now. So here it is. Here's your TAVR placement. So here's some of the stenosis that's happening. Here you go. You see the calcification, you see the fatty deposits, the hardening, and they're going to put a catheter, goes in, and they deploy this valve. It's a valve replacement right there. Boop. They kind of open it up and then pull whatever catheter out, and it just sits there. And there it is. It's amazing. There is a look at what the valve looks like. Looks like stitching that's going to have to go on. This is an open heart procedure situation. I know that they typically do open if there's going to be an aneurysm involved, and they may want to get rid of that aneurysm as well. But there's so many factors that go into determining what kind of surgery if you need it. And then there's a million and one factors that go into what kind of valve you might want. But so surgery or transcatheter valve replacement, they're going to figure out what it is to ensure long-term valve function, because nobody wants to go through this more than once. Okay, so there's a lot of links here that give you treatment options, plans, the whole 9 yards. You want to check those out. It's a lot to digest. I get it, but like you never realized how important that one little valve is, right? And it's pretty important to this community, because if you have an issue with the valve, that could potentially impact your aorta, and that opens a massive can of worms. So check it out. Let us know what you think. This is to be used as a conversation point between yourself and your physician if you're having any valve issues. So that's Aorta Valve 101. There you go. Anybody have any comments about this?
Let's just say hi to Christina Kohler.
Hey, Christina. Bo and Christina are with us today. Oh, I do that singing. All right, we are moving on. Again, so much stuff we've been talking about this month. All right, so let's get into cardiothoracic surgeons versus vascular surgeons. Big hot topic. Most aortic disease centers offer both, in addition to your cardiologist, in addition to possibly a God, my God, the word just left my head. When you have high blood pressure, what's the word? Nope, can't think of the word. But in addition to a high blood pressure specialist, that's not the name. I just can't think of it because it just left my head. And also electrical, heart specialists. They have a lot of different specialists in an aortic disease center. So then how do you know who to see? I've been asked before, do you see a vascular surgeon? I do not. And I'm dissected all the way to my iliacs. I've only seen a cardiothoracic. So let's talk about the difference. And this may give you a moment to pause and decide if you are seeing the right person, or if you should talk to your physician about adding a specialist, or maybe you have both and you're perfectly happy. I don't know, but I know that these questions are often asked, so let's talk about it, okay? But one of the things Adam wanted to ask was, what does it mean when an aortic valve is super tight? Do we remember what that means? Ready? Stenosis. And regurgitation was leaking, okay? Just a review of what we just talked about. All right. Let's compare two amazing types of surgeons that would help treat aortic disease, cardiothoracic and vascular. While the two usually work together to help repair aneurysms and dissections in the aorta, their expertise, their training, and common surgeries are very unique in their approach, okay? Let's start with a cardiothoracic surgeon. These women and men are our beloved heart specialists. They specialize in surgical repair of diseases affecting the heart and lung. Thoracic, that's going to be anything diaphragm and above. Again, heart, lung, anything that's going to happen in the chest, this is their specialty. This is what they've been trained to do. They complete medical school before starting residency, and during residency, these surgeons train to learn general surgery procedures followed by cardiothoracic surgeries, which focuses specifically on surgeries of the heart and lungs. And a good rule of thumb is that their main area of operation involves the chest organs and the surrounding blood vessels, okay? Common surgeries that are performed by CT surgeons include coronary bypass, valve repairs, heart and lung transplants, and of course, aortic aneurysms and dissections. They're going to be handled by cardiothoracic surgeons. Now, if we talk about vascular surgeons, these women and men are vessel vascular. They are vessel specialists. So that means their focus is treating diseases of the entire vascular system. This includes both arteries and veins throughout the entire body. So these include vessels that might be near or in the stomach, in our limbs, and of course, vessels of the heart, such as the aorta. Sounds a little confusing because they're pretty similar, right? And so similarly to a cardiothoracic surgeon, they complete medical school and sometimes spent learning general surgery. However, they go on to actually train in vascular surgery, and this emphasizes the surgical treatment of vessels throughout the entire body, not like super large vessels like the aorta. We're talking veins and smaller, and they're tiny, and I would envision them typically using the microscopic goggles all the time. The difference between a vascular surgeon and a cardiothoracic surgeon is that vascular surgeons may find themselves operating far away from the chest, and that might be an artery in the neck. It could be blood vessels from peripheral trauma, maybe a limb injury, carotid artery disease in the neck, something like that. It's going to be farther away from the chest. But when it comes to aortic health and CT, the CT and vascular superheroes often team up to diagnose and treat dissections and aneurysms. So this means that after you've had a CT scan, an echo, MRI, all of those results come in, they may actually together review your images and kind of make the decision the best way to repair or to treat what's going on with you. And based upon which part of the aorta actually has the disease or has been impacted, one might find themselves being operated on by a cardiothoracic surgeon, or you might find out you had a vascular surgeon do it. So, for example, if you're going to have open heart surgery, if there's an aneurysm or dissection that's needed in the ascending aorta, a cardiothoracic surgeon, they would be able to open the chest safely and repair the areas of damage, taking great care to ensure the great branches that come off of the aorta to feed blood to the brain, that they remain intact. Conversely, for type B dissection involving the descending aorta, further away from the heart, for those traveling down to the arteries of the leg, which would be the iliac, a vascular surgeon would be actually able to smoothly perform endovascular repair and deploy durable grafts to help fix any leakages of an aneurysm. So again, if you have a type B dissection and you're forming aneurysms in or around the iliacs, maybe also the renal glands, your vascular surgeon would be the one to consider deploying that graft we were talking about that can go in, like they put the valve replacement. You can deploy a graft instead of having to cut somebody open a lot of the time. That's an endovascular repair. They would be the ones to do it typically versus the thoracic surgeon, because again, it's further away from the chest. So again, let's talk about type A and type B dissections. Type A, which would be ascending, would be coming anywhere out from the heart and going up the arch. And then type B is coming down. Okay. And this is the DeBakey, I think, that divided it into, or no, maybe Stanford was dividing it into 1, 2, and 3. I can't really remember. But anything you see here in the 1 or 2 type, this would be considered type A. Type B, it started here. So anything that starts here in the ascending is a type A. Anything that starts after the arch comes down, that's a type B. Again, breaking it down to type 1s or type 2s gets a little bit more intricate in detail. Okay, but if you need surgery, understanding the roles of a cardiothoracic and vascular surgeon, it could be really helpful in planning your care if this is going to be a planned surgery. So the important thing is to know that regardless of who you or your loved one actually sees, the teams often work together to ensure that you're getting the best care possible and have dedicated a great portion of their lives to being trained to be experts in their field. If you want more information about cardiothoracic or vascular surgeons, there are links that are here in the post, which was last Tuesday, or it could have been Monday. Could have been Monday, could have been Tuesday. We've been doing multiple posts in each day, but you'll find it on our blog series.
Okay. Rob's here.
Rob's there. Hey, Rob, we got Bo, we got Christina.
I'll be posting a photo recipe for healthy stuffed mushrooms later today.
Yum.
That's what I said.
Yum. Okay, what's it going to be stuffed with? That's the question. Could be anything. Could be crab. Could be who knows, right?
Tell me you're from Maryland without telling me you're from Maryland.
Crab. Just don't stuff it with garlic. I can't do that. That hurts. That hurts me. All right, we are moving on. Diagnostic testing. See, last week was a big week. All right, we are back. And this one is from Duke. He's writing all about diagnostic testing. And these are the types of tests that are basically done for those that are in our community. Let's start off with the most common one that everybody believes is the only one that gives you accurate imagery. And this is just simply not true. Okay, this is the one that's going to be done in the ER, even if you are allergic. Okay, they are still going to give you pre medication or a CT scan. They're going to pre-medicate you typically with prednisone in your IV and Benadryl as well. If it's an emergency, they'll put everything in the IV. So you're going to be wired and falling asleep simultaneously as you're waiting for the scan, and because it works a lot quicker. I think it's like an hour protocol. And don't freak out when I say it could be an hour before you're allowed to have the test if you're in the emergency room. It's what you need. It's that or possibly going to anaphylaxis if you have a high degree of allergic reaction to CT dye. They just can't do it dry. It's just not going to be the same quality test. So, but they may, but it's not typically how it's done. Okay. So let's talk about CT scan and what it's all about. So the CT scan gives doctors a 3D image of your aorta, okay? And it's basically essentially like having many X-rays done at once. And I know when we hear that, that's also kind of scary because people have had these memes going around that, oh my God, I just heard a CT scan's like smoking 86,000 cartons of cigarettes. All right, don't read half the stuff you get on the internet. Ugh, I shouldn't even have to say that. Talk to your doctor. Talk to the doctor of radiology. Ask the question from the people who are doing these tests, okay? It's a cost benefit analysis. I think I had 15 CT scans in my first year. And if I turned off the light right now, I guarantee you I'm not glowing. I'm okay. It's okay. It's really okay. The CT and the abdomen or CTA allows for detailed visualization colloquially. If you know, you know, visualization. It's going to be one of those days of the entire aorta from the chest down to the groin. And a CT scan, they're used to diagnose aortic dissections and to plan for any kind of aortic surgery. And as we heard from Dr. Fisher, they're kind of also doing 3D printing of the aorta based off of these scans, which is even a more detailed way of determining what kind of surgery they're going to do because they can actually get in there. And now they're doing VR, is that what it's called? And they're going to like, video game, wear those goggles and travel through your actual
I am
aorta.
so excited when she
I'm so
lets us
excited.
see that. Oh man.
God, I cannot wait. I'm so excited. Um, all right, so these are used to plan for the treating or just to do it as a routine image for patients. And typically it's every year, or every 6 months, what have you. These are for patients that we know have aneurysms or other conditions of the aorta. And when a patient undergoes a CT scan, they are typically given something called contrast dye. This is very different from gadolinium, which we're going to talk about in a minute, which is given with an MRI. All right. So this contrast dye is going to be injected into your arm. So you're going to have an IV placed before you have the CT scan. And this dye will actually allow the doctors to see the structure of the aorta in even greater detail. You would typically get a gated CT scan, and you can ask, is this a low dose radiation machine? More times than not, they are, but you're entitled to ask those questions, okay? And we're going to talk about the dye in a little bit. So this is what the CT scan will show. You can see 99% sure we've got spine right here. Yeah, okay. Don't ask me, but I know I see a dissection right here, clear as day. I know that. I'm going to guess this is some type of organ going into intestines. Just my guess here again. But that's a dissection right there. Watch, I'm wrong, but I think I'm
It's
not.
it's like a liver, stomach, heart, and aorta, and you're
Something,
over here
yeah.
like there's a spine.
Over here. Well, over here, I mean, that's vertebrae. It is. This is stomach going into intestine, lung. I don't know. It's one of those things, but I know this is an aorta. I do know that. I didn't say it was a radiologist, just a person. Let's talk about the CT scan dye real quick for a second, and let's get real. You're gonna have this IV in you, and you're gonna get saline. And then they're going to tell you, okay, we're about to give you the dye. And it's going to get pushed by a machine pretty quickly. And you're going to feel it go into your arm. And it typically does not burn like it hurts, not like that. But you're going to feel the warmth travel up your arm, go across your chest. You may even feel it in your head, get a little heavy feeling. And you're going to feel it as it travels down your body. And when it gets into your pelvic region, you're going to feel like you have to pee. And I mean, feel like you got to pee pretty bad. If this is your first time having one, you may even want to squeeze the squeezer in the machine to be like, I got to pee. And by the time you even get that sentence out, the sensation's going away. This dye is just, it's wild. I think it's every time I used to have it, I was like, here comes the pee feeling. I'm just being real. This is what it feels like so that you can prepare yourself. Me personally, I used to take prednisone and Benadryl beforehand because I know I'm allergic. And the way I found out I was allergic, because I get asked this a lot, is the very first time I had a CT scan unrelated to this. In the middle of it, once the dye hit, I started feeling like I had a million bees stinging me on my arm. Just, it came on very quickly. And then I started feeling like I couldn't catch my breath. And so they gave me a drug to counteract it, and everything was fine. So now I pre-medicate before I would have a CT scan. However, there's Omnipaque and Visipaque. These are two different types of contrast dye. And you would think that if you pre-medicate and they give you one or the other, that you would still be fine. Well, I have proven to know that that is not true. Locally, I would always go to one particular hospital or radiology clinic uh, center, and they gave one of those particular dyes. Let's just say they gave Visipaque. And then I went to a sister hospital, and even though I was pre-medicated, by the time I got home, I started developing across my entire torso, front and back, what looked like a second-degree burn. And it was very painful, very hot, bright red. It was like that for almost 2 weeks while I was still on prednisone. And that was because they gave me Omnipaque. And so I had to do research because that's just how I am. And I wanted to know what kind of dye they gave me. And so because I had breakthrough reaction, I'm now not a candidate to have a scheduled scan with dye. So unless it's life or death and I'm in the ER, I think that they would still try to give me an MRI. If it was life or death, they would try their best to pre-medicate me heavily and then give me that very quick 5 to 7 minute CT scan. So that's another bonus of a CT. Okay. So that's just me. I'm an anomaly. I'm a freak. Weird things happen. Just letting you know and just being real and sharing everything with you. I particularly like MRI scans, which we're going to talk about now because I fall asleep in them and I have some really great dreams. Others that suffer from claustrophobia, uh, I get it. Oh, I just remembered. Part of the aortic team we were talking about before, hypertension specialist. Word just came to me. Just letting you all know. Okay, MRI scan. It's used as an alternative to a CT scan. Doesn't say it's better or worse. It's just an alternative. It provides great visualization of the aorta in very fine detail as well. But it uses a different technology. So this one does not involve any radiation. So if you're someone that has to have a lot of CT scans, I would recommend having a conversation with the ordering physician about the option of doing an MRI scan. One, there is no contrast dye. It's gadolinium. It's very different. Two, there is no radiation. Three, it's going to be longer, 40 minutes, half hour, somewhere in there. So if you're claustrophobic, again, don't ask about it. But if you're concerned about radiation exposure, definitely ask about it. And it's noisy. You know, they're going to give you earplugs. Some places will give you a headset where you can listen to some music. Sometimes MRI is not widely available in all hospitals, and it's usually not employed in an emergency situation, which we've already talked about. So one reason why a lot of people can't undergo an MRI is because they have certain metals in their body, such as a pacemaker. So there's a variety of reasons why people might not be able to use an MRI. Some of the things that I know a lot of people are just starting to consider would be for women, there's an eyeliner that is magnetic to lashes. you would need to not wear those that day, right? If it's magnetic and these eyelashes, after you put the eyeliner on, these eyelashes attach, that is magnetic. Do not wear that into an MRI machine. If you are wearing a clonidine patch or any other patch with that metallic background that sticks to you, you will not be able to wear that in the machine. If you have body piercings, you're not going to be able to wear those. You're going to have to take them from wherever they are in your body. You're going to have to take them out. Now, usually you can leave wedding bands in. I can feel stones vibrate a little, so I tend to hold them in my hand. I turn my wedding band around, I hold it in my hand. So there's a lot of things to consider when you're going to have an MRI, internal metal, external metal, and that's why they ask you a million questions. But if you can do it, talk to your doctor about it because the pictures are going to be fine. Okay. Here's your MRI scan machine. This is not like, okay, so a CT doesn't have a tube that you go through. CT is just this round circle. So it's pretty open. MRI, you're going into that chamber. Okay. You're going in. See, it's much longer. You're going to be in that chamber. All right. And echocardiography, or an echo, as we call it. So this uses ultrasound to visualize your aorta and your heart and the structures and the valve, the measurements, the function, does a whole lot. Okay. Uh, Echocardiography is pretty quick. It's benign. It's useful. It helps assess your heart function, how well your valve is opening and closing. So if you have stenosis or regurgitation, it can report back to what degree it is. There's also something called a transthoracic echo, or a TEE, and that can be done bedside. Um, it's not a scan of your entire aorta. So for that, you still need a CT scan or an MRI. So an echo, you're awake and they're like any other ultrasound using a wand. If you've had open heart surgery, or if you're female, there are some areas that they want to rub, let's say on the outside of your breasts or in the center of your breastbone, that might be uncomfortable. Uh, no more uncomfortable than uh, mammography, than a mammogram. It doesn't last long. Initially, after I had my open heart, I think it was more in my mind, but if they're pushing too hard in the upper part, it might agitate you from the wires perspective, but it's not going to be painful. Okay. Sometimes it's more in your mind, like it's going to hurt. A TEE, transthoracic echo, um, you're going to typically be put under some sedation because they're going to go in through your mouth, down your esophagus, or a transesophageal echo, which we're going to talk about in greater detail. This was just a transthoracic echo. So this is kind of what the echo probe looks like, rubbing on your skin, right? And we're going to see what that echo image looks like here. So here it is. Ascending aorta, left ventricle, something. I don't remember what they all stand for. I've looked at mine a million times and I look at them, but I am far from a professional on this. If you told me, oh, this looks like it might be the root and we might be here at the valve area, very well could be. I love asking questions. If I can see, if I can stretch my neck far enough, I'm like, what are we looking at? Show me this. And this, of course, I'm not going to tell me if anything's good or bad, but I always assume that it can't be too bad, because if it was too bad, they would say, wait here for just a minute. And they would go get a physician and make a phone call. And I've known that to happen to just a tiny bit of people, but it doesn't happen to me, so that's good. So yeah, transesophageal echocardiogram would be one where they're going to put you under some twilight sleep and place a probe down your esophagus, which allows them to get really close to your heart and have some really good images that way. So they tend to do that on schedule. I don't really know many people that have ever said they've had a TEE while waiting for potential surgery due to an emergency. Your typical number one gold standard that they're going to go to in an emergency is going to be that CT scan. In doing some rapid fire follow-ups, it's typically CT and echo or MRI and or echo. So again, food for thought with your doctors. Ask the questions why they choose what they choose. And, if you're cool with 45 minutes or a half hour in a machine and you don't have all of the things that are going to prohibit you from doing it, like metals in your body and stuff like that, ask your doctor about the idea of maybe switching to an MRI. Otherwise, if you're good, stick with CT. It's fast, it's easy, great pictures. If you don't mind that warm sensation, you're good to go. And if you're cool with the radiation exposure, then it should be fine.
All
So
right.
just food for thought to talk with your doctors about.
All right. So Rob got back to us about what the stuffing is going to be.
Mm,
Yeah.
what do we stuff
Uh,
in?
let's see here. Fresh homemade Italian beef sausage.
Ugh,
I know, right? I said, yeah, that's way better than crab.
so much better than crab.
And then he says,
So much better.
by the way, my CT from last week came back all clear. And I said, nice. Great to hear.
We like that. Scanxiety is a real thing. It's a real thing. We're going to talk about that probably in October. I mean, everybody has it to some degree, ranging like, 1 to 10 on a scale of how freaked out, nervous, questions, all that kind of stuff before you have a scan. Doesn't matter how many years you're into it. I don't know anybody who's like, skip to Malou, gotta have a scan, no big deal. I don't know anybody like that.
Now,
It's real.
I'll tell you, this weekend we had the caregiver meeting, and
Mm,
Scanxiety exists for them as well.
I'm sure.
And
I'm sure
and
it does.
it's very interesting to see the impact from a caregiver's
Hmm.
perspective, right?
Yeah.
We had we had one lady. She was basically trying to figure out whether or not her husband horseplaying with the kids was putting him at risk. And I was bringing her back to some of the things that we've been hearing about effort versus the pounds that are being attributed to this, like 70 pounds, 90 pounds.
Hmm.
And I was just like, listen, you have to look for the red flag, which is how much effort is he grunting? Is he, like,
Right.
but if it's easy for him to toss his children around,
Right.
like it's
And
about
breathe.
the effort. It's about
That's
the
right.
effort. Yeah.
Just don't hold your breath and no bearing down. But if you can toss a kid, you spin them around on your hand like a basketball, you're good. Just keep breathing. I've got that visual now. All right. Let's go on to pre and post surgical suggestions. So now we have discussed everything that could happen medically. We're pretty much through what would be part A of aortic dissection, the patient guide at this point. We're moving along to part B and into part C. So um, there's a lot of planning that goes into surgery, a lot of thought that goes into how to plan before surgery and what to plan for after surgery. And so we've been creating this list for a long time. It's a list that was created by patients for patients. You will find this if you download a copy of Aortic Dissection, the patient guide, you'll find it in the guide, but you're also going to find it on our resources section. You're going to find both of our website. So let's talk about some of these pre and post cares, okay? Strongly suggested have a loved one with you if you're going to have a pre-op appointment. Hey, have them with you if you have a post-op too. Who knows what mindset we're in, but having an extra set of ears during this situation, it's so helpful. I guarantee you there's more times than not that the patient person and the caregiver person hear two different things. And so if someone can write it down, that's very helpful. I mean, it's probably going to be in your after visit summary, but even if it doesn't make it, you want to have those notes, okay? Another person who cares about you and sees things differently, they're coming with their own set of questions. So to have them there, it's just an added bonus. It's just an added bonus. Okay. Make that list of questions and concerns prior to going if you're going to have a pre op, coming back in if you're going to have a post op, things you might want to ask your surgeon. And some typical questions might be how many hours do you think the surgery is going to last? That's important. How long will you possibly be in the hospital afterwards? What exactly is this procedure? Okay. Are we just repairing? Is there a chance for suspending my original valve, or are we going to have to replace the valve? What are the risks and benefits? There's a million different questions you can ask. What are you going to expect, both parties, caregivers, patients, when you wake up? How many IVs? This is important because when you're in an emergency situation, you don't get to ask these questions. So waking up lit up like a Christmas tree is also jarring to many of us. First of all, you can't figure out how to move. You got so many things hanging from you and so many IV trees and it's so much. So if you're going to have scheduled surgery, I think it's important to ask. It's something to consider if you are interested in knowing, okay? Pain management. That's my first question I always ask because I do not like pain. I just don't like it. Am I going to have a patient controlled button, okay, that I can push to administer pain control? Do I have to try to ask the nurses to give it to me? Do I have to hit the button? Am I going to be responsible for watching the time? Because I don't want to ask during nurse shift change, because then you're going to be chasing pain. It's inevitable that's going to happen. Can my loved one spend the night? Now, this is all screwy still in a post COVID world where numbers are ticking up. Can your spouse, loved one, friend, whomever spend the night with you? The answer is going to be no if you're going to be in ICU or cardiac ICU. I can tell you that right now. But once you're moved to step down, if you're not sharing a room with somebody, then you might have a greater chance of a yes. If you are, I'm not sure how that works because I've never really shared a room with anybody, so I really don't know. Um, if you're somebody who tends to become anxious and you know you have a scheduled surgery, you might want to ask for take the edge off medication that you can pop on your on your drive over to the hospital. Just if it's going to help you kind of keep that calmness about you before you go in. There's another one again. Ask if somebody can stay within the hospital. Okay, things to pack. Don't, number one, it should be on here. Don't pack a lot of anything. It's just more stuff you have to bring back. Plus, the hospital gives you 90% of what you're going to pack. Somebody suggested bring shorts or sweats, your own pajamas. You're not going to want to put on anything that's yours for a couple days. The gowns are so easy to wear and gives such easy accessibility to all of where your lines are going to be or incisions are going to be if you need to have any wound inspections or changes or whatever. If you know you're going to be there for like a week, then if it makes you feel good to have that comfort from home, sure. Somebody suggested silky pajamas. I don't want to get blood or anything on anything, so I'm leaving stuff like that home. I know they're soft on your skin and it makes it a little bit easier to take them on and put them off. I mean, take them off and put them on. Um, but if you're going to have open heart surgery, don't bring something that doesn't have buttons because it's going to be a while before you're going to put your arms above your head, okay, or reach behind you or anything like that. The hospital is going to give you treaded socks. If you don't love that look and you want to bring your own treaded socks, that's fine, but just do not bring plain old socks. If you want to wear some kind of slipper, make sure it's something that you don't just slip in and out. Make it be a shoe type of slipper because the last thing you need is to trip. So you want something that's very comfortable, easy to put on and take off. Now, some hospitals put you ever wondered why the socks are different colors? Okay, we've got gray, yellow, red, because they mean different things. It's not just because of sizes. Sometimes they mean fall risk, etc. So they may not even let you put on your own socks. But if they will, and you want to have your own socks because you want cute socks, then sure, bring a pair of socks. All right, women, don't even worry about a bra because a lot of times, not all the time, it depends on the hospital, you might find you wake up with a special bra if you're having open heart surgery. And it's typically a front closure bra. It's going to be your best friend. You should buy a couple pair while you're there in the hospital, whatever size they put on you. Ask for two more to bring home. It is so, it's so comfortable. It's so comfortable. Some hospitals don't offer it automatically when you wake up, but you can talk to the hospital staff about if they sell it in the hospital. Okay. Think about bringing some essential oils. And this would only really work if you are in a private room because you can't really don't want to bring oils. You don't know if your roommate has any allergies or sensitivities. So if you're by yourself, it's a proven fact that essential oils are very helpful in promoting stress reduction, anxiety reduction, and they actually can promote relaxation, which helps increase your sleep and helps promote positivity and better recovery. So these scents would be like lavender, chamomile, rose, frankincense. I will tell you that, well, we're going to get to the peppermint in just a second, so we'll hold that for a minute. All right, a lot of people say pack toiletries. The hospital will give you a toothbrush, toothpaste, some type of shaving cream, lotion, and a razor. Mm, powder, a hair slash body wash, all of that's going to be provided for you. Whatever you pack, you have to carry home. Just keep that in mind. So if you like having your favorite deodorizer, which I mean deodorant, I like mine because I like something that's the thick stick, a solid. I do not like roll-ons. I feel like I have to walk around with my arms in the air because you stay wet for like ever, which is what the hospital gives you. I don't care about the toothbrush and the toothpaste. I'll use what they give me. That's not a problem. I don't really care about, you're not going to care about, you're not going to put your arms above your head to shower your hair, number one. Not going to be for a little bit. So it's personal choice. It's just a personal choice. If you want your own smells, your own things there with you. I will tell you, do not forget to bring your cell phone and your charger. That sounds like would be a no-brainer, but so many people forget that. And sometimes the nurses have extra ones depending on what type of phone you have. But you may want to at some point reach out to the community, reach out to your family and your friends and let them know how you're doing. You will run out of power at some point, so you might want to bring that with you. Or you may want to play a game. Depends on how you're feeling. Everybody's different. Again, don't forget whatever you bring to the hospital, you have to bring back. If you talk to people ahead of time, they're not going to let you have flowers in the ICU. And I don't know that they're going to hold them and wait until you go to a step down unit if you ever do. So, cards, sure. Balloons, stuffed animals, flowers, it's not going to make it into the SICU. If you can have a visitor, accept visitors. Accept visitors if you're open to it and you're comfortable. Nobody cares what you look like. It's good for them and it really is good for you. You may or may not remember their visit, and that's okay too, but sometimes it might be very uplifting and make you feel really good. Let them know that you may just be taking a lot of naps while they're there because napping is important. Don't try to fight the nap. It's a way that your body helps itself heal. Okay. Don't try to tough it out and turn pain medication away. Now, you may have, let's say, had addiction issues in your past. That's a whole separate issue. But for those that can take pain medication, do not try to. This isn't labor. This isn't like I'm going to tough it out till I hit 10 centimeters. No, there's no, you don't want to be chasing pain because pain can increase your blood pressure, can increase your heart rate. You want to be calm. You want to be as comfortable as you possibly can. So if they offer it to you and you feel you need it, use that pain scale. When you see those faces in a hospital that are like super smiley and then like super frowny and deep dark red, use that scale for yourself. Try to figure out where you are pain wise and work with your team to determine at what point you should be having pain medication. Feel comfortable pressing the PCA or the patient controlled analgesia. Yeah. You can push it as often as you like. It's not going to give you medication until you're scheduled. So once you push it, you can push it like 10 times. It's not going to change anything. So just push, push, push. You're only going to get it when you're scheduled and when the machine allows it to be administered to you. Okay. People who are not given a PCA, don't hesitate to hit the call button and request pain medication. Try to do it early enough because, again, if there's a shift change with nursing staff, there's no way of knowing how long it's going to be before they bring you the medication. And trust me, you don't want to sit with that kind of pain. Now, when you're in the ICU, it's usually 2 patients per nurse. It's very personalized. They're not going to be upset if you ask for it. They're not going to be upset if you ask for anything. Get up, sit, walk, whatever you're told to do, as much as you may not want to. The more you move your body, the sooner you're actually going to get out of there, okay? Because it's just going to help move the anesthesia through the body, get the intestines waking up, everything's going to wake up, and you're going to actually feel better. You might be sleeping in the chair. You might walk out to the nurse's station, come right back and zonk right out, but you got to keep your body moving when the doctor says you should, okay? Ask somebody to take a picture of you. This is a very interesting, extremely personal decision. So even if you are in a dissection or emergency situation, my husband took a picture of me in the first hospital, took a picture of me just as the breathing tube came out, took a picture of me when all the tubes came out and my hair had just been washed and was up in a bun. And the difference in what I looked like is so incredibly profound that after I had the dissection, it all seemed like it was still a dream. But when I could see it on film, I actually saw the progression in recovery. So I saw me grimacing at the first hospital. This was when he found out that I was having a dissection. I think he was concerned I was going to die. And so he took a picture. That would have been a really bad last picture. And then when I had the tubes come out, he was just so thankful that I made it, that he took the picture. And I'm now thankful that he took it. And then uh, once all the tubes came out and I just had the nasal cannula for oxygen, I mean, oh my God, like this look on my face of, oh my God, this feels so much better. And I could actually see how things went from going down to the lowest point on their way up. So it's again, personal choice. You may not remember a lot that happens to you. So seeing the pictures might help you put some pieces together and fill in the blanks. That's really going to be up to you. Okay. Ask a close friend or a family member to provide updates to the community and to your family and your loved ones about your progress. This can include phone calls or Facebook notifications. You can also create an account under caringbridge.org. So, Caring Bridge does not have to have a donation component. I think you can attach one if you'd like to your favorite charity, but it's mainly used as a way to say, here's what's happening with so and so, here's where we're at. You can include daily, weekly, whatever updates, pictures, the whole 9 yards, and friends and family can actually leave some messages of encouragement. Ask friends and family to bring cards, games, whatever they like. This may not be to help you pass the time away, but it's definitely going to help your loved ones pass the time away. While time flies by very quickly in a hospital, to some people, it is just moving slow as molasses. So, and as a patient, if you're sleeping a lot, your loved one can at least maybe play some solitaire or play Yahtzee, whatever the case may be. I know that once they've been there for a couple of days and they know that you're out of the woods, it can get a little antsy. So instead of leaving, people want to be there. Maybe they could play a card game or something. Okay. Start asking questions about your surgery while you're in the beginning stages of recovery, because you may not even remember why you're actually in the hospital. It can be very taxing on your mind having open heart surgery, whether scheduled or emergency, it doesn't matter. You might ask the same questions over and over again. That is okay. It's not a sign that you've had a stroke. It's anesthesia, and it takes a toll on your brain. And it's okay to cry. Crying is so common after any surgery, but 100% common after open heart surgery. Open heart surgery has been proven to create some depression symptoms. It might last just for a couple of days. It could last for a couple of weeks. It should not last for months. So if you're still finding that you're in this depression state months after your surgery, you really should talk to your doctor about it. You do not need to sit and suffer, and there are ways to help you through that, working through it with therapy and or if you needed medication. But anesthesia, that makes you have the blues. It makes people cry. This has been scientifically followed. It's normal. As a caregiver, do not be concerned. Just be supportive. Crying really helps the brain heal. It releases what you've been feeling inside. It's okay. This was the peppermint I wanted to get back to. Tried and true tip for using peppermint. Now, when you have had a catheter in your urethra and that comes out, which is what is collecting your urine typically in a bag, when that catheter is removed, which is not it's not painful, it's just not pleasant, but it's going to feel a lot better when it comes out. You're not going to have to urinate right away. But when you do, you may find that you can't, because maybe your bladder hasn't fully turned on yet, because you're scared it's going to burn, and it may be burny, it may not be comfortable. So the best thing you can try is some peppermint. Now, you may not be able to eat or drink yet, so you want to ask your loved one to bring some Altoids or any other peppermint charm. We called them charms growing up, like a sucker. What else do we call them? Like Lifesaver or something like that. Or bring toothpaste with peppermint, or bring essential oil and put a droplet in the toilet. Smelling that actually does this immediate relaxation. And for a lot of people, it allows them to urinate, just comes right out. I know this because this is what a nurse in the hospital did for me. I had a problem with going to the bathroom after the catheter was removed, and I was begging to be recathed because I had to go so bad. And she said, hold on, and dropped some peppermint oil in, and I just started going. It was wonderful. So I have given this advice to try. It can't hurt you, to a couple people, and it's worked for them too. So anytime I have scheduled surgery, I always make sure I have peppermint with me because I do not want to be recast. That would not be pleasant, right? So something to think about if you want to try. Here's another great tip. If you have, for whatever reason, a drop in potassium, please know this is a known fact and should be known by all medical staff. If you have to have potassium in your IV, it hurts really, 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 really badly. Hurts, burns, really, really hurts. And the nursing staff or anybody who's administering the potassium should know that they can give you more saline and drip it slowly. Sometimes the nursing staff just turn it on really fast with a little bit of, it's always diluted with saline, and it's 2 bags that go into one, but they'll dilute it, and they dilute it with a little bit of saline. The majority of it is potassium, and they'll put it on high. The bolus goes really fast, and your veins can actually become red and inflamed, and it's really very painful. And I've learned all these things the hard way. So if they say we need to give you some potassium, your blood test came back that it's low, you can ask to take it orally. So there is a liquid that you can take, and it tastes really gross. It's very, very like salty. That's nasty, but it's like a shot. They can also give you pills. They're very large pills. So letting people who have issues taking pills let you know. But there's a couple different ways of taking it. Now, depending on your situation, they may want it in you faster than slower. If you have to have it in IV, ask for someone if they can have it turned on very slowly with more saline to start, because you're not going anywhere anytime soon. So there's no rush. If there's a real rush and it's an emergency, then you take it however you need it to get it in your body, obviously. But again, these are all just things to talk about with the nursing staff and doctors. Talking about nursing staff, they're amazing. They're amazing. I mean, the doctors have done a great job, but the nurses nurse us back to where we need to be. But you might not mesh with them. Not all of us mesh with our certain friends or our neighbors or coworkers. It is the same when it comes to nurses. So if you are having challenges from a nurse or a communication issue, maybe someone is from a different country, you're not understanding them, they're not understanding you, personality, they're having really bad days and they're seemingly taking it out on you, and they're just not being as gentle or empathetic, ask for the charge nurse and ask to see if you can have your nurse for the day changed. They will make those changes for you. This is your care. Don't worry about it. It's not like you're reporting them and getting them in trouble. Just get the care that you desire. Find out from your physician if they're going to be prescribing cardiac rehab. Cardiac rehab is not just something that gets accepted and you get to do. So cardiac rehab may be turned down by your insurance company, especially if you are not having any surgical repair done to your valve. A lot of insurance companies look at the valve as part of the heart, which it is, and they do not look at the aorta as having anything to do with the heart, which it doesn't. But if you've had a dissection and you've had this open heart repair and nothing was done to your valve, maybe it was resuspended, a lot of insurance companies are like, nope, not paying for cardiac rehab. So you kind of want to talk about that because some patients have problems with stamina. They have problems with strength, especially in their arms, their shoulders, their posture, and their breathing. You don't have to wait to start cardiac rehab. You can talk to your doctor about asking if they can give you a script for physical therapy. You will not be turned down for physical therapy to fix the things I just mentioned, because that's what physical therapists do. And you could find a physical therapist who has had experience with open heart surgery patients, and they will actually start with you day one on diaphragmatic breathing, just ways to control your diaphragm and control your emotions and your physical self through breathing. That might be all you do for the first 2 sessions. And they're going to teach you how to work with your posture while your sternum is healing. And it's my understanding it takes about 3 months for your sternum to heal. They can also teach you about how to get out of the bed. Even though you're shown this in the hospital, they can work with you to make sure you're not twisting, that you're using your arms, that you're not holding your breath and you're straining. They can help you how can you reach for something overhead? Like, what's the best way to do some of these things that you're physically not going to be able to do for a while? And then eventually they can help you build up stamina and build up confidence. Okay, so this is important, and this is good work that the PTs can do. They're not going to put you on any EKG leads like you would find in cardiac rehab, but they are going to be able to monitor you. And a good PT will know to take your blood pressure and your heart rate and your oxygen level before you begin anything, and then repeat what happens while you're doing any activity, and then report what the numbers were a few moments after you stopped doing this activity. They would report this to your cardiologist, and then keeping your cardiologist kind of abreast of the situation. Okay. All right, mental health. As described earlier, survivors have discussed with us the feeling of just being blue or general depression or what have you. You could be experiencing symptoms of post traumatic stress. Let your doctor kind of work with you to make that diagnosis. Do not hesitate reaching out to a licensed clinical social worker or somebody who specializes in PTS treatment. That might be EMDR therapy, etc. There's also a great guide about the emotional mental health. We can get that link to you. We've shared it before on our website. This was written by Gretchen McCarrick and another woman out of Johns Hopkins. It's solely dedicated to mental health in aortic disease and aortic dissection. The patient guide, really, it's parts B and C, are open for all patients. So whether you've had open heart surgery due to aneurysm repair or valve replacement, you don't need to have had an aortic dissection to use our guide either. And there is a section in there about mental health and emotional well-being, so you can check that out too. We also offer support group meetings here. Very different. They are led by patients, led by survivors. You might want to look into joining one of those and having an opportunity to interact with other patients if you're looking to garner some experiences or ask questions. If you're looking for a fun place to hang out, then you want to join our hangouts on every Thursday that happens at 2 p.m. Eastern. So again, long-winded post, and we need to get through the rest of the week, but these are important things. If you have any other suggestions that we have not recommended, please leave a comment here on the website, here on our YouTube channel, or email us at info@aortichope.org.
I'm so glad you got all the way through that.
Dan, that's one of my favorite posts.
I know it is. I see how you get all, yeah, I see it. I
Yeah,
see it. So,
get all animated.
Christina was saying that last week she had a CT scan that was also all good, no changes to diameter. When
That's
you were
awesome.
commenting about the peppermint and the water,
Yeah.
Christina said, or turn on the faucet.
Yes.
And
Well, yeah.
yeah, I was
Turn on
like,
the
I wonder
faucet.
how many people that works for. When you were
Yeah.
talking about the potassium, Rob had he says, when I got potassium in the hospital, I had an infiltration. Ouch. What does
Yes.
that mean?
So it can infiltrate and actually leave the vein that it's put
Oh,
into, is my understanding. Yeah, these veins can swell. Sometimes the IV can infiltrate, and so then it goes into your cavity, your
ouch.
body cavity. Yeah. Blown veins. It's horrible.
Okay.
Potassium is terrible. Important, but bad. It's all right. We're moving on to the next post. Haven't you guys wondered what half these terminologies mean in the aortic disease world? I mean, so many times I see triple A and they interchange it for ascending aortic aneurysm, but it really means abdominal aortic aneurysm. Come on, like there's certain things that these acronyms all mean and words mean. So this was a post about all of the things that you've been hearing. Acute aortic syndrome. What does that mean? What does the aortic root mean? What does thor- thoracoabdominal aneurysm mean? Antegrade cerebral perfusion. Look at these big words. I'm glad I didn't have to say in our guide. Oh, not even going to do that one again. Type A, type B, aortic insufficiency, aortic regurgitation, aortic stenosis. There's atherosclerosis, another big one that was fun to say. Glad I didn't have to spell it. They're all in here. They're all in here. And it's actually uh, thanks to Corrigan Health System, we got this from their page and decided to share it here with all of you. Penetrating atherosclerotic ulcer. Check out what that could mean. Pseudoaneurysm of the aorta. Scary, but read it. That's important. all of these words are here for you to check out, refer back to. So when you hear them mentioned, because our doctors might not always have time to explain everything, and when you hear them, your brain might just shut down, you have a glossary here that you can refer back to. Corrigan Minahan Heart Center. So that was the glossary. Okay. Friday fundraiser. We said this was only good for the weekend. We extended it through September 19th. This was an opportunity for you to get one of our seatbelt covers. If it is a domestic order here to the United States, we're asking for a $10 donation, not our normal $15 donation. So this is the chance for you to load up on these now. They make great gifts. Even if someone doesn't have aortic disease, you can order it in Medical Alert. And you have 3 different colors, black, yellow, and red. And what these are is they get wrapped around your seatbelt and they get Velcroed in place with an information card that goes on the inside of the belt cover. We have them in abdominal aortic aneurysm, thoracic aortic aneurysm, aortic dissection, Marfan syndrome, Loeys-Dietz syndrome, vascular Ehlers-Danlos, and Medical Alert. So again, you can pick any of the sayings we've mentioned. This is what it looks like, wraps around your belt, yellow, black, or red, with a $10 donation through the end of the day on the 19th. And you can also order one of our aortic disease awareness ribbon car magnets at the same place by clicking the link below. That is located on our Hope Shops section of our website. So check that out. Okay. Survivor Series. This week was John Grom, and it was his 80th birthday. So exciting. What a great day to learn about his story. So on his birthday, it was the 22nd anniversary of September 11th, but it's also his little anniversary. Of course, he says it doesn't compare, but it was really important to him because it was his mission to spread awareness of the risk factors of an abdominal aortic aneurysm. We don't get too many stories of those here, although we're fully open and want to hear about them. But his story, very interesting story. And I don't want to read through this whole thing now here, but his goal since surviving his abdominal aortic aneurysm is really to talk about it more, to basically use his story as a public service announcement. Okay. Take a look at it, listen, check it out. The key here is with an aneurysm, there's typically no warning sign. There is no symptoms. And while these aneurysms tend to form in males that are over 60, that may be overweight, that may have been smokers, you need to understand that this can really happen to anybody. So even though things typically can happen to certain people, it can happen to anybody. So it is important to understand aneurysms, whether thoracic or abdominal, and learn about it and learn about your medical history and talk to your doctors about if there's a chance that it could run in your history, in your family history, and should you be receiving any diagnostic testing or monitoring. So check this out. The story is down below. Thank you, John Grom, and happy belated birthday. Okay, Sunday, very exciting day. It was actually the World Health Organization Patient Safety Day. We had just found out about this because we heard our friends over at Think Aorta in the UK and Ireland were really going to use this day to participate, to kind of inspire millions on that day, Patient Safety Awareness Day. So in a powerful and inspiring testament to the strength of the human spirit, Tony Sutherden, who is a survivor of a life-threatening acute aortic dissection, shared his harrowing story in a video released by the global patient-led Think Aorta campaign for World Health Organization World Patient Safety Day, which was September 17th. Tony, who defied the odds and survived despite initial misdiagnosis and delay in recognizing his acute aortic dissection, became a beacon of hope for patients and healthcare providers alike. His story highlights the global patient safety issue of misdiagnosis and delay in acute aortic dissection, which the patient-led Think Aorta campaign is addressing. The video, which we shared, is very emotional, but also very inspiring. It's a tribute to the indomitable spirit of those who face patient safety issues in life-threatening medical conditions. Trigger warning. It includes a recording of Tony at home alone, making an emergency ambulance call that saved his life. By sharing his story and this call, which is jarring, uh, it's part of the Think Aorta campaign. He wants to help raise awareness of the need to improve patient safety through early detection and timely intervention in acute aortic dissection. And as we know, aortic dissection is a life-threatening condition involving a tear in the body's biggest artery, the aorta, which carries blood, oxygenated blood, from the heart to the brain, limbs, and vital organs. World Patient Safety Day from the World Health Organization is an annual event that emphasizes the importance of patient safety and encourages open dialogue between patients and healthcare providers. It aims to reduce the risks and harm associated by healthcare, associated with healthcare by promoting awareness, accountability, and effective communication in healthcare systems. This is worldwide. The theme of this particular safety day for 2023 was engaging patients in safety. And Think Aorta is an amazing campaign to do so. Think Aorta was actually established by a national patient charity, Aortic Dissection Awareness UK and Ireland, in 2016 in partnership with the Royal College of Emergency Medicine, the Society for Cardiothoracic Surgery in Great Britain and Ireland, and the charity Heart Research UK. High impact Think Aorta educational posters are now available with them, as well as Think Aorta US. You can find all of that material that's free to download and to request on their website, thinkaorta.us, here in the States. And it's available now in the native language of 50% of the world's population. There's campaigns right now across North America, South America, the UK, Europe, Asia, and Australasia, which I had to look up because I did not know what that was. I thought Australia was the right word. So I was learning something new. Here in the US, the campaign is led by, it says it's led by Aortic Hope. We're actually in support of this campaign. Think Aorta is actually its own nonprofit here in the USA, and that's Think Aorta US. But we've been endorsed, I wear two hats. Think Aorta US has been endorsed by the Society of Thoracic Surgeons, the Society for Vascular Surgery, and the American College of Emergency Physicians. Tony believes that his story can actually be a catalyst for change, inspiring patients and healthcare providers to prioritize patient safety, improve education and communication, as well as foster a culture of continuous safety, improvement in healthcare organizations worldwide. His video is poised to touch the hearts of millions and create a lasting impact on patient care. Check it out. That video went live on yesterday, Sunday the 17th. There's a link inside here. Again, trigger warning regarding this video. This does contain the actual 911 call that was made when he was at home alone, and he knew he was in trouble. He knew he was experiencing an issue, and it made me want to call my local 911 to get my call, because I think I remember my call very differently, and I think I don't know how I think, if I want to hear it or not. Maybe I do. I probably do. Maybe I don't. I probably do. It's been long enough. But this is an incredible story. And to be able to have an opportunity to really showcase Think Aorta, because every organization, I don't care who you are, everybody is thinking aorta, or they wouldn't have an organization to begin with. If doctors were not thinking about the aorta, if emergency medicine, if EMTs, if people weren't thinking about the aorta, there wouldn't be patients that this community can help, that this community can perform research on, that this community can offer symposiums to. Everybody's thinking about the aorta. It's two simple words that have made such a difference in so many lives across this planet. Tony's is one of them. I highly suggest you check it out. Okay, we're almost done for this week. Every single week, so much information. Okay. Common medications. I am not going to read all these common medications to you because I will butcher the words terribly. Spironolactone is one of them. All right. Easy to understand presentation offered to us from Dr. Kristen Watson, all about the common medications that we see in the aorta community. You should check out this PowerPoint presentation. It includes many, if not all of them, okay, as well as potential side effects, interactions, etc. Check this out. This is to be used again as a guide for conversation. So if you're on metoprolol, and you don't like that medication, which is a beta blocker, and I know this because it ends in LOL, The luls are beta blockers, and you feel tired and not like yourself and foggy head. That does not mean that all of the drugs that are in this classification are going to make you feel that way. So, again, quality of life, if you think your quality of life is being negatively impacted by these new medications, log it and take that information to your physician, because maybe nebivolol or Bistolic won't give you the same side effect, or labetalol. Maybe labetalol would be equal because they're kind of interchangeable, but Bistolic probably not. Same thing with ACE inhibitors and the ARBs, and these are angiotensin receptor blockers. I can't believe I'm learning all of this, but you have your TANs, which are the ACE inhibitors like losartan. That's one that's well known. You have the ARBs, which is like, I can't remember them now because now that I said I knew them all, I don't know them all. But there's a lot of drugs. There's diuretics that are in there, different, Lasix, different types of medications, clonidine patches. If you're somebody who doesn't absorb meds, you can take a clonidine patch and ensure that you're getting some amount of medication. There's so much that I'm just saying, have a conversation. Have a conversation with your physician, log what you're feeling from your medications, and let he or she determine if there's some other type of medication you can try. So check out this common disease medications that are prescribed in the community. You can also find that in the research section. Okay, we're almost done. We're on events. Still have some events happening throughout the remaining 2 weeks here. We will be showcasing the Aortic Hope 5th Annual Hope Campaign video. So this started off calling it, "What Does Hope Look Like?" Or "This is what Hope Looks Like." We had a variety of different titles way back when we started this in 2017. I think it's 2018. And we started this because there was campaigns going around for a long time that showed different well-known individuals who have succumbed to aortic disease, saying, look at who you have this disease in common with. And the further a lot of us on the board of Aortic Hope got through our own recovery management, we realized, well, it was too scary to think I had something in common with somebody who passed, but more inspirational and hopeful when I started thinking about all the people I talk to on a daily basis. Now, I have things in common with them. And so when I thought about all the people who created the various Facebook pages and organizations, even those who have since passed since creating it, the legacy that lives on in the community members that interact, that's who I've got something in common with. And I wanted to personally, along with other board members, showcase those people that really make us hopeful, that by their stories that they're sharing and their experiences that they share give us all a degree of hope. And so that's kind of what hope looks like. It's what it started off looking like. And it has morphed into the community members showing what hope looks like in their daily lives. So we're going to showcase that tomorrow on September 19th, Aortic Disease Awareness Day. We're so looking forward to it. We're also going to showcase a couple other exciting things as well tomorrow. We have our hangout every Thursday. We have 2 more hangouts at 2 p.m. You want to just hang out and have a good time, feel like you're in a virtual Panera shop, Starbucks for your decaf coffee, and you're just shooting the conversations with some people, then join a hangout. You never know what you're going to find. But what you aren't going to find is a lot of serious conversation and swapping ideas and stories. That would look more like a support group meeting. And our next support group meeting is at the end of the month, the last Wednesday on the 27th at 7 p.m. Eastern. That's going to be a support group meeting. That's where we may have doctors, they slip in sometimes and they talk to the community. That's where you can ask questions and talk to people about your experiences. So we do have one more this month. And we also have our live event with Dr. Ben Udelman. So we're going to be talking about everything aorta, everything that has to do with think aorta, how we've realizing that aortic disease is so much more common than anybody even realized. Some of the things that's happening with the emotional survey that they put out through Maimonides Hospital, and just taking your questions, any of your questions, and hopefully giving you a way to present your question to your own physician and in a way that makes sense. So Ben is just so charismatic. Dr. Udelman is just awesome. So come join us on the 26th at 4 p.m. Note that time change. Note that time change because they usually happen around 6:30 or 7. This is going to be at 4. So that's kind of what we've got. Unfortunately, the Ask a Doctor with Dr. Prakash that is happening on September 19th is going to need to be rescheduled for November. So you'll have to think about bringing your questions at that time. And hopefully, we'll have even more information about what they're finding through the results of their exercise study. And then we kind of also want to talk about exercise and what that looks like on the immediate ends of recovery versus long term. So that would be interesting to hear about as well. So that's what we've got from our events. That's what we did for a busy, busy week. It's a lot of talking by myself.
Yeah, yeah.
But I want to thank Bo, Christina, Rob. Thanks so much for at least checking us out and saying hi. And got another whole week that we're into right now that we're going to talk about on Monday at 3 p.m. Eastern Standard Time. So again, please click like, please click subscribe so that you're notified every time we go live, and click that bell. And we hope to see you same time next week. We look forward to it. And thank you so much for joining us here during Aortic Disease Awareness Month. We'll see you soon.